Welcome, everybody. Tuesday edition of Clinical Problem Solvers Video Morning Report, evening edition. So, very excited to have all of you join. 5 p.m. East Coast, 3 p.m. West Coast. Sorry, no, 2 p.m. West Coast, 3 hours behind. And we have very excited to have Magnus, who's all the way in Denmark, present a case. So we have East Coast. Amol will be discussing with me, and Magnus will be presenting from Denmark. So before we get underway, Magnus, you want to unmute and sort of say a few things about yourself?
Yeah, sure. Hello, everyone. I'm Magnus. I'm a physician from Denmark, currently doing a PhD, and very, very happy to be part of the CB Solvers, and delighted to share a case today for Ravi and Anmol. Really looking forward to that. So yeah, it's going to be great.
Thank you, Magnus. And before we get underway, I just want to mention to everybody out there, if you do have a case, please reach out to us, to the email, to coordinate with us to put a case together, and we can help you do that. And that way you can feature as a case presenter, even put that on your CV if you're applying for a match 2025 this year, 2026, sorry, this year. So do reach out and ask to present a case, and we definitely would love to feature all of you in that role. Also, Anmol will co-discuss. Kindly just jumped into the lukewarm seat. How are you doing, Anmol?
I'm doing good. I'm very excited before the before the body actually knows that I'm discussing. I think we should start. And I'm very happy. This is an unplanned discussion, and so I'm very excited for the next 1 hour. Thank you for the opportunity.
Awesome. And we have our scribes today. So Mary is going to be scribing. How are you, Mary? If you're able to unmute. And Vinny will also be helping. Go ahead, Mary. Yeah.
So I'm sorry.
That's okay.
Thank you so much.
All right, no problem. And Vinny will be helping Mary today. How are you, Vinny?
Yeah, well, hey everybody, super excited for the discussion. Good luck, and I'll start I'll share the screen, and Magnus, feel free to bring us the first slide.
Awesome. And Julia will be doing teaching points. So how are you, Julia?
Hi everyone, I'm Julia, a medical graduate from Brazil. Very excited for today's session.
Awesome. And without our scribes and also teaching point members, we couldn't do this. So much appreciated to all of you. So we'll start with the first aliquot. Magnus, take it away.
Sure. So this is a 48-year-old woman with a chief concern of diffuse itching for 2 days. And I'm going to stop there.
Wow, interesting first aliquot. What comes to mind more? I guess the question at this point is not what's causing, but how do you think about itching in a patient?
Yes, this is very interesting. And I think the complaint, which is not very much discussed on the virtual morning report, so it will be interesting to go through it. So itching, in scientific terms, we can call it pruritus. I think we can think about it as something that affects the mast cells, increasing the release of histamine that can actually present in a typical way, typical pathophysiology, we can consider that to be causing itching. But itching can represent a variety of causes. So number one cause that comes to my mind in this case is some sort of allergy or anaphylactic reaction. So I would want to know if the patient actually took any recent new food intake or any new clothing item or any new soap, any new shampoo, something like that that is new to him, which could potentially trigger the allergic reaction and the diffuse itching. And along with that, I would examine the skin properly for any rash, if I can localize any rash. Number two cause, which I can think about, diffuse pruritus, is something related to gallbladder, that is cholestasis, but I'm not sure if it can present that acute. So I know that cholestasis can present with diffuse itching. Then one of the causes is just with sometimes the hot weather can trigger dry skin that can lead to diffuse itching. Because I remember I was once at a medical camp, and at that point of time, a patient came to me with diffuse itching only, and I was just attributing his symptoms to dry skin. But then I think gallbladder disease is also something to be considered. But right now, I'm weighing more towards some allergic or anaphylactic reaction in this case. It will be interesting to know what the past medical history is, and what are the proper present history. Yeah, that's what I'm thinking right now.
Amol, I'm so impressed from all the duration of your presence on VMR, all the different cases that I've learned from and that I've been taught about. Those are the experiences that you're pulling from. So all these cases, bile salts and so on, and then external forces. The itching is, or this diffuse pruritus is very interesting. I could just start like hitting off many different causes, but at its basic element, what are we dealing with? We're dealing with skin is the issue, right? But is it a primary process? You know, when you have pruritus, you have, the skin is very irritated. It's a inflammatory disorder. So inflammation is at the heart of the matter. Now we have to understand what's driving the inflammation. The causes are just many. So you're right. The question is, I guess at this point, is what could be the driver of this process? So it could be external forces. So many things. Unfortunately, I was out gardening and I got just bit by chiggers, mosquitoes, all sorts of things, and that caused quite a bit of itchiness this past week for me. But there are certain conditions that are internal to the skin or internal to the body, which could just cause this disturbance. And sometimes pruritus is just terrible. It's just extremely debilitating. So I definitely will look for more data as far as external or internal forces that are probably driving this. And I see John just joined. So John, welcome. I know you're a little late due to clinical duties. So our junior discussant, and more kindly stepped in for a bit, then we'll bring her back in to discuss this remarkable case. So this is a 46-year-old woman with a chief concern of diffuse itching for 2 days. Anything you can add to this if you do get somebody? Usually I see this if I'm in the outpatient clinic, but have you come across any patient like this with these complaints?
Yeah, it could be a challenging one. So when I hear itching, sometimes I wonder, first thoughts, is this a problem with perhaps good look at the skin to see, like, is there any rash developing? Sometimes it may be a skin condition and you're itching before the rash appears, and it's a little bit of a different internal schema for the approach to an itchy rash, or just itching itself. Thinking about, it could be anything from the benign to the can't miss, from just environments, dry, just diffuse dry skin, to things like I've seen HIV infection present with diffuse itching. Unfortunately, hopefully not for this patient, but like invasion of this, leukemia invading the skin, to metabolic problems like renal failure and hyperbilirubinemia, medication side effects. So a careful skin exam, and also just kind of keep an open mind to, could there be something developing? What's the time course? Sometimes people will have also a itch that rashes if they start to scratch it, and you just get these linear excoriations. So yeah, I'm just going to say, like, what's the background of the patient, if there's any chronic medical conditions, medications that could be a culprit, and good social history about environmental exposures can be helpful too. We had this recent rapid session where, I forget who presented it, but there was this whole family of people, and they just had this diffuse itching after they jumped in the pool. And it was related to, amongst the metabolic bucket, they had it's a symptom of hyperthyroidism. And we were all pretty familiar with hyperthyroidism's, eye disease, but it can have GI and skin problems too, including itching. So pretty broad differential. And I think skin exam, social history, medication, exposures, maybe where I'm looking to make progress. And hope I'm all like, stick with us here. I think 3 is a company, not a crowd. I'd love to have you continue, exploring this patient's case with us.
Absolutely, yeah. That this is going to be quite a case here. I think with the rash, what's interesting, the dynamic you brought in, John. You know, when you get a rash, right? You look at the rash, but that rash may not be the primary manifestation. What do we do secondarily to the rash? You scratch it and you exacerbate it. So usually with rashes, you have to understand the primary component, which is the underlying manifestation of whatever's on the skin. And then what we're introducing to that is by scraping and irritating, further exacerbating this as well. So when examining rashes, you do have to understand this dynamic that patients tend to do to it. But without further ado, let's return back to Magnus. Very interesting first aliquot. On to the next one.
Excellent discussion by all 3 of you. She had been feeling well until 2 days ago when she started developing itching all over her body. And it has been increasing in intensity, which has prompted her to visit a primary care clinic. She hadn't noticed any rash or skin changes, and there were no worsening or alleviating factors. She had not used any new skin products or new medications, but she did say that a few weeks ago she was experiencing headache and joint pain for some days, for which she was using some Tylenol and ibuprofen. The joint pain was mainly in her bilateral wrists and fingers, but she had not seen any swelling or redness, and she did not see a doctor at the time. And the pain has now completely resolved. In terms of her past medical history, she has hay fever, for which she uses a nasal corticosteroid spray. Otherwise, there is no past medical history. And family history is not significant. She works in a kindergarten and has 3 children. She rarely drinks alcohol and she is a non-smoker. She doesn't take any drugs and she has no recent travel history, and she is monogamous with her husband. She's allergic to grass, but has no other known allergies. And just a quick physical exam at this point, so she was generally well appearing, and the skin exam was notable for dry skin, but otherwise unremarkable. And that concludes the second aliquot.
So very interesting data here. Anmol, you want to take the rest of the HPI? What does this add to your initial discussion? You mentioned something which is now elaborated on in the HPI.
Yes, I think this is very interesting. The past medical history is in the history of present illness is significant for some joint pain in bilateral fingers. So whenever I hear about joint pain in fingers, I would want to know which joints are involved. If it is the MCP joint, PIP, DIP, if we are actually focusing on the joint pain, I think that also is something helpful. And if I'm not sure if these symptoms are related to itching or not. We might tend to relate, and the patient might tend to relate because of recall bias, but we have to understand if these symptoms are related or not. And if the joint pain, in fact, could even represent viral arthritis, could represent so many things. So we have to take a little bit of pause here and understand what is going on. But in case they're related, then that points to a systemic cause of the pruritus at this point. And she has a history of allergy too. So that also makes me think if this whole body itching is representative of some allergic reaction to a product. I'm not sure, but I believe there is something systemic going on if we are relating these symptoms. Yeah, that's what I think about the history of present illness.
Absolutely wonderful. I'll bring in John. What do you think at this point with what Anmol said?
Yeah, so some like thoughts are, when I hear the finding about the dry skin, I think I want to be careful about how much weight I put on that, because it could be. I certainly would try some non-scented moisturizer and see if it gets better with that while I continue to investigate and think about this. And I think kind of layering on some of like what I'm all saying is, it sounds more like a perhaps an inside job than an outside job, something more systemic as opposed to some kind of insect bite or new sheets or some kind of skin exposure, given it seems like it's diffuse and it's symmetric. And in the background, we have these arthralgias and headache that we kind of, it's like almost translate that to perhaps a recent, viral syndrome or tick-borne illness or something like that, which could be just a common enough thing that it could be true and unrelated, or thinking about ways that the two could be tied together. What do you think? Are you reading true, unrelated, or a link for the two together? Where's your head at, Ravi?
So what's really standing out to me is two things mainly. One is what we commonly see. I love test questions. I deal with a lot of test questions, and working in a kindergarten to me is like that's a milieu of all sorts of different infections and viruses. So are we dealing with something that could be external to the body? Remember we talked about internal conditions that could spur on pruritus, or external conditions, the dry skin as well. It's sort of like it's a breeding ground for all sorts of problems there. And with the dry skin, definitely could spur on this presentation. But what's interesting, Mark actually also caught on to this other issue, is like there's no rash, but there's a lot of itching. And what comes to mind is what Anmol initially had discussed is conditions like metabolic conditions. You could lump them into, if we were going to formulate a framework, we could start talking about endocrinological conditions, hematological conditions, malignant conditions, endocrinological conditions, and so on. So a lot of them may not manifest with a rash, but because of inflammation, you may actually have this development of this severe pruritus. So at this point, I don't have anything to really latch on to signify that this is likely the condition. Like you kind of talked about hyperthyroidism, John, right? So hyperthyroidism, the people that had gone into a pool together and so on and had developed this, we're not seeing any information that could potentiate a condition like that. Again, we're not getting any signal for maybe a malignancy, nothing for a metabolic disturbance. So I think getting more data will be very powerful. But I guess just that I'm very interested in, and I would kind of do an analysis after what kind of conditions, or why would you get itchiness without a rash? So that's a very interesting question. Is it really a red flag? I don't know. There could be some accumulation of toxins or various things like you talked about, John, uremia, kidney, liver, these kind of issues. But I'm not sure if it's a red flag at this point, but it definitely has piqued my curiosity, and we'll see what more data Magnus has for us. Any other thoughts before we turn it back over to Magnus?
I'm thinking, like, I'm trying to be honest with myself and ask, like, if I'm seeing this person in clinic with a couple of days of itching, recent prodrome of some like viral sounding problem, would you get blood work at this point, or just have them try some moisturizer and come back if it's not getting better? Just thinking about the triage, like honestly, like in the absence of like systemic symptoms, weight loss, anything concerning, I feel like since we're in the morning report setting, it's probably there's going to be more to it. But I'm just trying to reflect honestly with myself, wondering like, would I get my blood work at this point, or would I not be worried enough? So maybe like kind of prompt that to the people in the audience too. Like, what do you think? Would you get labs now? Would you have close follow up? What's the approach to triage?
That's a really interesting question. Yeah, we always talk about cost efficiency, high yield medicine, and at this point, is there anything that's sort of garnering your interest in something that needs further study? I think we do tend to get a lot of the studies in the background just to make sure we rule out all these different causes here. But you're right, I'm not getting any sense of this being a very insidious sort of a process that I need to make the patient inpatient and do a study. But we could do outpatient studies and then call the patient back to see what's going on. Unless there's another dynamic where the patient has other areas that are infected. I mean, this definitely sounds like a multi-system process. There's the headache, there's the joint pain. Is that an autoimmune phenomena? I don't know. There's not much more information that Magnus has given us, but the physical exam may actually yield some clues. Anything else, Anmol, before we turn it back over to Magnus?
No, I totally agree. And if that will also change if the patient presented to the outpatient setting or the inpatient setting, how serious the patient is about their symptoms. And I think that would prompt the further investigations. The history of some allergic reaction also makes me think about some type of dermatitis to atopic dermatitis. But at this point, I'm just saying differentials, that's it. So waiting for the next aliquot.
Okay, back to you, Magnus.
Sure. So she was sent home with antihistamines and moisturizing cream, but returned 2 days later with no improvement and still complaining of this severe itching. And now she had also developed or noticed some yellow discoloration of the eyes, as well as dark colored urine. Reviewer systems was negative for any chest pain, shortness of breath, abdominal pain, nausea, vomiting, and there were no fever, weight loss, or night sweats. And the physical exam, she had a temperature of 37 degrees, a blood pressure of 145/84, a heart rate of 68, a respiratory rate of 16, an O2 sat of 100% on room air. And in general, she was in no acute distress. Her skin and sclera appeared mildly jaundiced, and she had scratch marks, especially on her arms, abdomen, and thighs. There was no lymphadenopathy appreciated, and heart and lung exam was unremarkable. Her abdomen was soft and non-tender, and her musculoskeletal exam was unremarkable as well. And I'm gonna stop there.
Wow, absolutely eye-opening aliquot there. And now, Anmol, you can really focus your gaze on what the problem is, as you had elaborated on earlier on. What do you think? What does this do for you at this point?
Yes, dark urine can represent many things, but in this case, it makes me focus on cholestasis and increased bilirubin. So I think dark urine can represent anything ranging from dehydration or rhabdomyolysis or hemolysis. So definitely at this point of time, I am concerned about the patient having hyperbilirubinemia, likely indirect hyperbilirubinemia. I'm concerned if there is some sort of hemolysis going on there, but it will be revealed on the LFTs and the serum bilirubin. But that is my thought currently. Interesting would be to get the CBC and see the hemoglobin and knowing the past hemoglobin, if that is actually happening. My concern is about indirect hyperbilirubinemia right now, but I'm not able to still think about the cause, which I can associate it with the joint pain or everything. But yes, cholestasis does explain the pruritus in this case.
There we go. Wonderful. Yeah. At this point, what's interesting, you're kind of stopping yourself from diving into like, this is a primary biliary process, but could this be something prior to the liver, maybe hemolysis and so on. So, but what's interesting, yeah, the bile salts are excessive, and they do a funny thing. They actually go into the bloodstream, and then they interact with all sorts of sensory nerve receptors and cause all this flare up. So no rash, but itching. So initially what Magnus had mentioned was there was no rash there, but it was just like diffuse itching. So you have to think about toxins and things like that building up. And here we have definitely one of the toxins that you don't want, that shouldn't be in the skin or the bloodstream. And I mean, the itching can be just terrible in these patients, and it can be nonstop. And although the mechanisms, histaminergic release can be one of them, so the Benadryl and so on that we may give actually cannot alleviate this itching. It may help momentarily, but there's 3 or 4 other. If you look at the causes of the itching with bile salts, there's 2 or 3 other mechanisms that I don't remember, that I can't get into, but there's other mechanisms where it can cause itching, and Benadryl won't be able to alleviate that. At this point, John, anything you have to add to Anmol's great discussion of this case?
Yeah, like right on with we have a new piece of data that we can latch our clinical reasoning hats onto, and we start saying, I think I would have done the same thing as the clinicians here, is like some moisturizer, antihistamine. If it doesn't get better, call back. Kind of, it was like a style branch point there. Like if you think somebody's not going to follow up, but if it's somebody who I think will follow up, I would have done the same thing as the people in who were taking care of the patient here. And now we have this, Yellenstein, the jaundice, agree with, like, translate that in my mind to the hyperbilirubinemia, which explains the itching. I'm not quite ready to commit to direct or indirect hyperbilirubinemia until I see the labs, but we can try to postulate. So with indirect hyperbilirubinemia, you may have that secondary to hemolysis, or for some reason you have impaired conjugation due to an enzymatic defect, which may be unmasked by any kind of febrile illness or increased stressor on the body. And certainly plausible given the recent arthralgias and headache that came into play. And on the side of intended direct hyperbilirubinemia from perhaps some kind of cholestasis, either from intrinsic liver disease or external compression. We had a patient with a recent viral illness and taking some NSAIDs, so the possibility of drug-induced liver injury or some kind of, on my radar, but let's think of it like an autoimmune process whenever I hear about the joint pains. So that would be the branch point I go down to if I see it's mostly direct hyperbilirubinemia. So the labs will be the next branch point for me. Am I going down the indirect or the direct pathway? And do I need to be, thinking about some imaging to help guide from there? So yeah, that's where I'm at.
Absolutely, yeah. This goes back to the initial question you had about would you do labs and so on. But what Magnus had laid out, yes, give some medication, see if they alleviate, because there was no other signal, right? But now patient comes back, time is the biggest differentiator, and the patient is manifest with this jaundice, and now we have the green light to go after something. So back to you, Magnus. I think the labs will definitely help shed light on what's going on.
Amazing discussion, and ask and you shall receive. So in terms of her labs, she had a hemoglobin of 14.2, white blood cell count of 4.7, platelets of 224. Her creatinine and electrolytes were normal. ALT was elevated at 1,690, AST 1,230, ALK-Phos 502. Total bilirubin was 3.3, with direct bilirubin at 2.2. Albumin was 3.5. Her INR was 1.1, and her LDH was 467. She had a normal CRP at 0.5 and a normal TSH as 1.32. We also did a ultrasound of her liver and bile ducts that showed no signs of biliary obstruction. There was a well-defined homogeneously hyperechoic lesion in the right liver lobe, about 3 centimeters large, with no internal Doppler flow. And the rest of that exam was unremarkable. And I'm gonna stop there.
Very incredible labs there. I'm going to switch it over to John. Take first stab at these labs. What comes to mind when you have this unique pattern of liver chemistries?
Yeah. So I'm definitely that helps me shift away from, although we have an elevated LDH, we seem to have a center of gravity in the liver with a mostly direct hyperbilirubinemia and transaminases that are 4 digits, which actually has a relatively short differential of things that can cause it. So, but it's like the patient's pretty sick. And I get these labs back. I'm definitely going to admit them to the hospital for close monitoring and further workup. So, I think favoring the short list of things we can consider. We didn't hear about any reason to have systemic hypotension under perfusion of the liver, which can lead to shock liver or ischemic hepatopathy that can cause very high transaminases like this. You can see it with viral hepatitis, with autoimmune hepatitis, Tylenol toxicity. Sometimes with choledoco, every once in a while you will get transaminases that are this high. But And I've seen like some just really bad drug-induced liver injury. I will include here too. Let's layer this pattern on. We also have. I'm just looking at the imaging again. So we had some biliary. Was there biliary dilation, Magnus?
No, there were no signs of biliary dilation.
Okay, yeah. So which it still could be like an intrinsic problem with the results. If there's not like dilation, this kind of always perhaps some credence to like autoimmune, viral, or drug-induced process. This liver lesion, I'd be looking back to see if there's any prior imaging to see if this has been there before. But certainly concerning. And next process in getting progress here, I might save, definitely test for our viral infections, test for some first pass of autoimmune labs. And if we don't have a clear answer soon, I wouldn't delay too long in terms of looking for like tissue to assess this liver lesion. What do you rest think?
What do you think, Amol, at this point to add to this discussion?
Yes, I think the labs are very concerning. As Dr. John said, the differential for severe acute liver injury is quite small, and we need to concentrate on those three things of ischemic hepatitis, viral hepatitis, and drug-induced liver injury. With the relative leukopenia, I'm thinking more towards a viral hepatitis too, but it's important to send the serologies for hepatitis A, B, C, all of that. That is very important here. But with the age, it is giving a flavor of autoimmune diseases too. So currently, I think, and then there's a third thing that the patient recently had some joint pain. So we don't know the Tylenol levels or how much acetaminophen she actually took. So there are three possible causes, or I'm not sure if the autoimmune picture can actually lead to this much elevation, but according to me, the one Tylenol and another viral hepatitis can lead to such presentations. So we need to be concerned about those findings. And LDH, acute LDH elevation can occur in acute liver injury. That is what I have learned. And I actually saw a case about that also, that LDH can be explained from the liver injury. But right now, it will be important to save the liver. To see if the synthetic functions are there. And I think it would be important to get, if the patient had taken Tylenol, it will be advisable to get Tylenol levels to check, and the viral serologies. But my schema about a liver lesion is not that great, so I'm not sure what that could represent. But yeah, these are my thoughts.
Absolutely wonderful, Anmol and John. I think you try to explain every key feature of this case, multiple layers. So just starting with system one thinking, the differential or the DDX for elevated liver chemistries. You talked about drugs, hepatitis is key in this. Doing the SETA labs is absolutely vital to rule that out. And then also acute cholecystitis could manifest with such elevated liver enzymes. Autoimmune is interesting. You've now reached out and try to integrate all these non-specific features that the patient is manifesting with. You can have this with a virus, so it makes viral hepatitis even more likely in this case. And system one thinking, what comes to mind again with viral hepatitis and MAS. Now you're trying to integrate this MAS into this discussion that you've put out, both of you put out really wonderfully. And one thing that comes to mind is, could this be HCC, and could this be somewhat obstructing? And the patient doesn't have key features or findings of cirrhosis, but Hep B can actually lead to HCC without going through cirrhosis. So that kind of makes it interesting. But then again, I can't really say that's the answer without proving it via testing. So Magnus likely will give us some viral hepatitis testing in the next aliquot. But at this point, I think there's nothing that the patient took. So it's not drug toxicity. This is not acute liver failure, not chronic liver disease. Platelets are fine. Usually signals that we usually see, INR and so on, and albumin are not terribly affected. and this isn't long-standing. The patient hasn't had any manifestations before. This patient doesn't have any findings such as obesity or alcohol use disorder or any of those common risk factors for that. So we're purely dealing with an acute insult on the liver. What is causing it at this point, I'm not sure, but there's no obstructive finding here per the ultrasound. The answer may lie in this mass, and then also thinking about what could manifest as a mass. Usually when you have masses within the liver, the ALP goes way above, and the ALP is kind of high here, but we're dealing with actually ALP, bile, indirect bile elevation, cholestatic and hepatic abnormalities here, but the hepatic is outweighing the cholestatic features here, although the patient has pruritus, but those liver chemistries are very, very generous. And we have to kind of think about that. But ALP can be a signal of masses within the liver. So you kind of have to wonder about, and more did talk about not having a very robust schema for masses. So definitely that's something we would have to take a look at. So additional imaging might be key here, maybe getting a CT to see what exactly is this cystic, is it fluid filled, does it have an organism, parasite, things like that. Things that we have to think about. Any other thoughts before we turn it back over to Magnus?
Yeah, I agree with that. I think what are the non-invasive ways we can make progress? I think my next go to is try to better understand the space with either like a triphasic CT or an MRI to better characterize this lesion, along and seeing with what the serum test can tell us. We already talked about the viral hepatitis panel, doing our like ANA, AMA, AMSA, LKM, kind of do these serum, and then if the imaging and the serum studies don't give us a clear answer and the patient's not already getting better, then it may be that tissue is the issue. If it is HCC, it's one of the things that we can often diagnose based on the clinical picture and the characteristic imaging findings on a triphasic with an elevated AFP. But we'll see these non-invasive things first and see what happens with the patient, and then determine if we need a more invasive approach to get our DX.
Okay, back to you, Magnus. Absolutely wonderful presentation of this case.
Awesome discussion. So I have some additional tests for you. So she was negative for hepatitis A, B, and C. Her ANA was also sent and was negative. Her anti-smooth muscle antibody was negative. Anti-mitochondrial antibody also negative. And her anti-CCP and ANCA serologies were also sent and were negative. And the next aliquot will reveal the final diagnosis.
Okay, the data that we were waiting for kind of has limited or taken off a lot of things from the table. Where does your mind go now? So there's one more aliquot to really decipher what's going on. We'll start with you. What do you think, Amol, at this juncture?
I think if the just one data point is left, and I think if I actually think again about the severe acute liver injury, the three things comes to my mind. And if we dissect that, ischemic hepatitis does not seem to be in the case in this patient. She does not present with any shortness of breath or any things like that. And even an IBC size can help with that, but that is very low down in the list. Hepatitis or the viral hepatitis, we have ruled that out. Definitely, we don't know about the drugs yet, or if she had any overdose of acetaminophen, which could actually lead to drug-induced liver injury. Or I think some antibiotics can also lead to cholestatic picture of drug liver injury too. So that is quite high on my differential. And I think even if it is not the diagnosis, we should rule that out. And about the liver mass, the one liver mass, I'm not sure about that, and because I'm not sure, I was not saying in the last aliquot too, but I think there is some sort of a mass, I don't remember which one, which can actually be precipitated by oral contraceptive use. There's something, but I since I'm not sure, I won't relate it to this case. But definitely my thoughts are about the drug intake in this case. And if that is negative, then yes, as we are saying, we need to characterize that lesion properly, that why is the patient having this liver injury with the advanced imaging as we were discussing. And even if that does not reveal the diagnosis, ultimately at the end, we can go to the invasive test like liver biopsy. But first, I think we should rule out the drug-induced liver injury. That's what I'm thinking.
Absolutely wonderful thoughts there. Yeah. What do you think, John, at this point?
Yeah, so I think the autoimmune theory becomes, at least amongst the usual autoimmune, the most common things we think of, less likely. I like where Amal's head's at, and then watch the final answer end up being like a Tylenol level that's through the roof. Because like it's probably either like an MRI or tissue will be the next steps to give us the DX. So yeah. I think in terms of drug exposures, was it just like NSAIDs? Was there anything else that she took between there and here, Magnus?
No.
Okay. Yeah, but NSAIDs can cause a drug-induced liver injury if it's not something she'd had before. And the mass, it's reasonably sized, but the mass is something that needs to be explained. But it's like, why would that in and of itself cause her, if it's not compressing the bile duct, to have these LFTs through the roof and be jaundiced? It's just like the clinical presentation seems a little disproportionate with like the size of the mass itself, which makes me think of something more involving the liver, systemically. I'd probably advocate. I'm not confident in underlying diagnosis. I'm ready to learn. I'm excited, but perhaps tissue may be where we need to go next if advanced imaging doesn't give us the answer. So yeah, humble myself. I'm not quite sure what this is going to be. I'm excited to learn from you.
Yeah, wonderful discussion, both. Yeah, I don't know how much we should invest in this mass. There's a mass, is something there. Is this malignant? I'm not really getting the sense this is a malignant process. So you have to then open the door on the landscape of non-malignant masses that could be homogeneous, hyperechoic. And yes, initially I was thinking, okay, the dreaded hepatocellular carcinoma, but there's not a lot in the background of this patient that could suggest hepatocellular carcinoma. There's no risk factors, and there's also no cirrhosis. The Hep B was excluded. So what could be an analogous sort of a mass like HCC? You can have actually in children something called hepatoblastoma. Although at this age it's unusual, what came to mind was a case that was presented at one of the regional meetings where a young veteran in his 20s had right upper quadrant pain, and on imaging was found to have hepatoblastoma, but it usually won't manifest to this degree. So, but then if you study the other kind of sort of masses like this, you could have a focal nodular hyperplasia. It could also be a AVM, something along those lines. But again, yeah, it doesn't make sense to me. But definitely I think to get to this point, the imaging definitely helps us, but maybe getting some tissue will disclose what exactly we're dealing with. Any other thoughts before we send the mic back to Magnus?
Yeah, I think I just would like to add one more thing, that I think people in the chat were thinking about parasites, and also if we're thinking on that lines, so we can get the differential leukocyte count and see if the eosinophils, what are the eosinophil count is. But yeah, I think the problem representation of this case would be because before we get the final diagnosis, that a 48-year-old woman only with a history of allergy and a recent infection, likely viral infection, presented with diffuse itching and found to have severe acute liver injury with cholestasis. Incidental homogeneous hyperechoic lesion was found in the right liver lobe, and thereby we will get the diagnosis. But I love the discussion and love the case.
Absolutely wonderful, Amal. Going back to the basics and outlining a problem representation. You know what's kind of interesting now? By just spelling out the features of this case, kind of makes me think, as the chat is talking about, base rate, more than likely a benign lesion. It will be, I said it was AVM, but hemangioma was the word I was looking for. So most likely it's a red herring. We may have to then divert our attention back to the labs to decipher what exactly could be causing this. So we'll send the mic back to Magnus for some teaching.
Sure, and absolutely amazing. Love the discussion and teaching by all of you. The liver lesion was believed to be hemangioma by radiology, and her EBV serology came back with a positive IgM and IgG and a negative nuclear antigen IgG. So the final diagnosis was the primary EBV infection with EBV-associated hepatitis. And yeah, for me, this case was an uncommon presentation of a very common disease. And it reminded me that primary EBV infection in adults over 40 is relatively rare and may not present with the classical triad of symptoms we know is fever, pharyngitis, and lymphadenopathy. We also know that EBV infection often causes asymptomatic elevations in liver enzymes, and jaundice is also seen, but in less than 5% of cases. But it's more frequently seen in older adults. And in terms of the clinical course, so her liver enzymes downtrended without any treatment over the next couple of weeks and were completely normalized 6 weeks after. And her pruritus was effectively managed with cholestyramine. So that's all I had, but thanks again for amazing discussion, and thanks for doing the scribing and teaching points to all of you.
Magnus, what a amazing journey through this case. You know, we learned so many things: itching, liver issues, mass, and now viral, I guess, conditions, which are systemic. So just talk, it was interesting. I was reading about this before, but the human herpes viruses and the manifestation. So along with EBV, you could have also CMV, which has a predilection for the liver and also has this sort of multi-system process as well. So you got like HHV2, HSV, HHV3, VZV, HHV4, EBV, HHV5, CMV. And then I think a little while ago, we talked about POSI, HHV8. So all of these viruses can manifest with all this. And you said headache and then joint pains, although the joints were not dysmorphic. So very interesting case. Yeah, it was interesting. I've had cases with CMV, but yeah, EBV like this, very, very unusual. But I really appreciate you educating us today with this magnificent case. Any reflections on more than John?
Yes, I definitely have something to say, but I actually saw just this case and I was supposed to present it someday on the VMR. I literally saw it in the clinic. We actually saw that patient in the outpatient clinic and we had to shift him to the hospital because this patient was 35-year-old presenting with fever and had severe acute liver injury with splenomegaly. So his his tests, monospot screening was negative outside, and then EBV IgG was positive, but IgM was negative. So everybody was concerned what is going on, and his PCR came out to be positive. And that patient actually had hepatomegaly and just fever, no pharyngitis that we do expect. So seeing these labs reminded me of that case, and I was thinking all throughout that that EBV could be a possibility. But then I was like, 48-year-old female, no, EBV won't be there. So I just did not say that out loud. But I didn't. It's very great to learn that EBV can actually present in 35-year-old, 48-year-old people, and they won't even present with pharyngitis to you. So yes, I love the case. Thank you so much for sharing.
Yeah, very, very cool case. Wasn't so high on my radar. I was looking for ways to tie the recent viral syndrome to the jaundice and elevated LFTs. Like on the first pass, I don't routinely always send like the human herpes virus family of tests off the bat, because I'd heard of like case reports and morning reports where human herpes viruses, CMV cause like somebody to have a really sick liver, but it was often in profoundly immunocompromised patients. So it wasn't just as high on my radar, but that's kind of something I'll keep more upfront, that even immunocompetent people may have very sick liver from CMV, EBV, etc. So really cool case. Thanks for sharing.
And thank you, Anmol and John. Fantastic discussion. This is amazing. And we'll turn the mic over to the wonderful Julia for teaching points.
Hi, everyone. So we had this 48-year-old woman presenting with itching. And the first thing that we discussed was the itching. That is called pruritus, is produced by mast cells that release histamine. And as Ravi mentioned, the pruritus is an inflammatory reaction to some driver within or outside the body. For example, some allergy, anaphylactic reaction, for example, food, shampoo, meds, skin products. Also can cause it by hot water, gallbladder cause, mosquito bite, and HIV infection, as well as leukemia, renal failure, and endocrinology pathologies like thyroid disease. And in the approach of itching, it's important to look for some rash in the skin. So the next I'll reveal the past medical history that it showed joint pains, and this points toward a systemic cause of the pruritus, for example, some virals, mosquito bites, and this pruritus without rash and also with some systemic symptoms points also towards a systemic condition, for example, endocrine or renal disease. Going on to the physical exam, the jaundice reveal some hyperbilirubinemia that could be indirect or direct. The indirect from hemolysis or conjugation problem, and direct from intrinsic liver disease or some biliary obstruction. And since in this point, the pathology is not driven by histamine, some drugs such as diphenhydramine will alleviate just momentaneously the symptoms. Going to the labs from this case, the elevated liver function tests show some pattern of that can be autoimmune, viral hepatitis, ischemic, or drug-induced liver injury. And also, Omopred mentioned that elevated LDH indicates acute liver injury. With viral hepatitis, with this elevated LDH and a liver mass, this points toward NCC. And having viral hepatitis ruled out with all of the labs being negative, hepatitis A, B, and C, this points toward some medication-induced hepatitis, including antibiotics or contraceptive use or NSAIDs, but the mass, this will not explain the liver mass. So the final diagnosis was ABV hepatitis that is rare in immunocompetent adults. And also this, all of this picture can be caused by another herpes virus such as CMV, HHV, and so on. So thank you so much, everyone.
Thank you, Julia. Fantastic discussion and teaching points. You're doing a wonderful job. And Magnus, absolute magnum opus of a case. Please do bring back more cases like this. And thanks again, John and Anmol. Fantastic discussions. Take care, everybody. Have a good rest of the evening. Bye.